Yeah, Assalamualaikum and a very good morning to everyone. Welcome to the CPC for today, which is conducted by the Department of Medicine, Faculty of Medicine, UKM. I am Dr. Rafeah, your chairperson for today. So with me, we have four doctors who will be discussing on the case. They are also the panelists. So I will introduce to you one by one. Okay, firstly, Dr.Nur Shairah Mohamad Fazial. So she is the registrar in the Department of Medicine, Faculty of Medicine. So she'll be the hot star for today. And secondly, Dr. Chong Guang, our clinical specialist in Hematology Unit, Department of Medicine. So the session will be mainly conducted by Dr. Chong. And we have two other panelists, Associate Professor Dr. Wong Yinping, consultant pathologist in the Department of Pathology, and also Dr. Emilia Mohamad Rosli, a consultant radiologist in the Department of Radiology. So I would like to welcome both of you. Thank you for agreeing to be the panelists for today. So I will just brief a bit on the conduct of the CPC for today. So Dr. Nur Shairah was given this case scenario. So the same case scenario which were distributed to everyone. So she was given the scenario last Friday actually. And Dr. Chong and subsequently Dr. Emilia and Prof. Wong will be giving the rest of the information gradually, okay, as we go along this session for today. So I think without further ado, I will pass this platform to Dr. Chong.
Thank you, Prof. Good morning, I'm Dr. Chong from Medical Department. So allow me to share my screen first. Together with me today is Dr. Shairah. We will start with the case presentation. Dr. Shairah, are you ready? Okay.
Yes.
Okay, thank you. So we will start with our CPC, the conference title of The Calm Before the Storm. So we start with the presentation. Madam N is a 67-year-old lady, had COVID vaccinated 3 times. She has a comorbid of T2DM for about 20 years, target organ damage with both micro and macrovascular complication. She also has underlying hypertension, dyslipidemia, IHD post-bypass in year 2021. So she presented to us with feeling unwell for 2 months, mainly because of loss of appetite and loss of weight, about 10 kgs, had intermittent fever, night sweats, portative cough for 2 months, mainly whitish sputum, watery diarrhea for 2 weeks. She did seek a treatment at the health clinic and give her 1 course of antibiotic, but the symptoms is not resolved. So what further history would I like to obtain from the patient, Dr. Shairah, at this moment?
Thank you so much, Dr. Chong. Sorry, at this point, so because this is, we are dealing with a prolonged fever of unknown origin, I would like to acquire further history of any for the tuberculosis, whether the patient had hemoptysis, any TB contact or night sweat. And other than that, because of the prolonged fever itself, I would like to acquire further history of any family history of a malignancy itself, since the patient have diarrhea for 2 weeks, any altered bowel habits, any recent traveling, whether we are dealing actually, whether this patient was traveled to domestic or actually abroad, whether we are dealing with malaria, and any recent water activity. So to exclude whether this patient dealing with leptospirosis. Other than that, I would also like to acquire further history whether this patient had pets at home or any wild animals, whether we are dealing with brucellosis. Other than that, I also would like to acquire history that whether this patient had connective tissue disease symptoms, whether it's a bit unlikely in elderly women, but I still will ask because we are dealing with a fever unknown of origin, whether she had a malar rash, any alopecia, any joint pain or joint swelling, any further history I would like to acquire regarding the drugs, whether she had take other drugs over the counter, any supplements, and any other supplements or drugs over the counter. More than that, a risk factor for the malignancy itself, our acquired history of whether this patient had history of smoker in the past, whether dealing with chronic alcoholism. So this is actually a risk factor of malignancy as well. Other than that, I would like to acquire that this patient whether had a sick contact foremost from the hospitalization patient. For example, in immunocompromised patient, whether we are dealing with the viral etiology, EBV or EBV or cytomegalovirus. So that will be the further history that I would like to acquire, Chong.
Okay, very good, Dr. Shairah, very detailed history. So this patient has no complaint of hemolysis. She denies any shortness of breath. There's no angina symptoms. There's no connective tissue symptoms. Did not notice any swelling. No history of TB contact. No history of outside food for the diarrhea. And then the recent traveling history to Japan about 2 months ago. But at the on, she has no history of any jungle trekking or any swimming in river. There's no pets at home. So she also denies any traditional medication or supplements, deny any high-risk behavior, no known drugs or food allergic. There's no family history of malignancy. She's married, blessed with 3 children, is a retired dentist, non-smoker and non-alcohol consumer. Is there any history we want to acquire further before I proceed?
At this point, because this patient also have a long-standing diabetes, I would like to know the occupation of the patient itself, and daily activity, whether she had recent saw activity to rule out amyloidosis in a prolonged fever or actually Rose Garden syndrome disease here.
Yeah, so she is a retired dentist, and then she has no any garden works recently.
Thank you.
So we proceed further. So this is a medication list that patients on. You can see for the IHD, the cardiprine, bisoprolol, fenofibrate, Atowa, Pento, and for the diabetic, she's on metformin and also this basal bolus insulin, atropine, and insulatard. So on presenting to us, her BP actually is normal tensive, about 118/53. The heart rate was 90 beats per minute, respiratory rate 18 breaths per minute. His febrile temperature 38, and the sugar is 16 millimole per liter, DXT 16. So on physical examination, she alert, but now a bit coated, it's not jaundice. CVS S1, S2 were heard. There's a bit less anoscopic scar noted. Lungs has cause palpitation over the left lower zone. Abdomen is soft, non-tender. Liver, 1 finger breath palpable. Spleen not palpable. There's no stigmata of chronic liver disease, and no finger clubbing as well. There's no liver neuropathies and no petty edema. So at this point, what is your provisional diagnosis at the moment, and any investigation you were to send?
Right. So at this point, my provisional diagnosis, I'll treat this patient as a partially treated pneumonia, since this patient had an antibiotic exposure. But because of the fever unknown of origin, another differentials would be tuberculosis or malignancy or connective tissue disease. So my investigation, I would like to request, first it's actually the complete full blood count.
Sorry, Dr. Nur, if I may ask, okay, what other differential diagnosis that you have in mind? Okay, based on the history and also physical findings that Dr. Chong has given you.
All right. So another differential diagnosis in a 67 years old woman with long-standing diabetes with fever unknown of origin is, number one is infection. I would like to rule out there's a tuberculosis, number one, viral in origin such as CMV or EBV, fungal infections or amyloidosis in long-standing diabetes, malignancy, like in elderly ladies, such as hematological malignancy or GI malignancy, could deal with lymphoma, or in GI malignancy with this patient. Other than that, it could be still is a down the list is a connective tissue disease, Prof. Yeah. So at this point, that would be my differential diagnosis for this patient.
Okay, in the physical findings, okay, apart from what Dr. Chong has presented, any other findings that you would like to elicit or ask Dr. Chong?
Okay, I would like to acquire further regarding whether this patient have it is highlighted there is no lymphadenopathy, whether this patient is cachextic or pale. Other than that,
Okay, so yeah, the general well-being of the patient.
yeah, any murmur heard, because we are dealing with fever of unknown origin, whether we are dealing with infective
Yes.
endocarditis. The lungs itself, any bronchial breathing and possibly at the upper lip region to exclude tuberculosis or cavitating lung lesions. Or we are dealing with the abscess or empyema. We have evidence of pleural effusions, stony dullness, reduced air entry over the lower zone. This is only, liver is only one finger breath palpable. However, in a fever of unknown origin, I still cannot rule out whether we are dealing with abscess in long-standing diabetic. Okay, I would like to elicit further regarding the connective tissue disease sign and symptom, whether this patient had malar rash, any joint tenderness, any joint swelling, non-scarring alopecia. So all of this, so I would like to look at that.
Okay, so just now you mentioned about malignancy. So if I ask you to prioritize, okay, the differential diagnosis for malignancy, okay, what would be based on the history and also physical findings that are presented here? So what would be the most likely malignancy here?
We could dealing with the GI malignancy. Hematological malignancy, since the liver one finger breath.
Okay, and there's also no lymphadenopathies. Okay, so a bit difficult to say at this point whether you're dealing with, lymphoma or any hematological malignancy. Okay, okay. Anything else that you would like to add, Dr. Chong?
Yeah, just to clarify with the Shairah, she's look a bit lethargic, but it's not really cachextic looking. Severe has no murmur. Lungs, apex zone is clear. There is no malar rash or any described rash. And apart from that, other examination is quite normal. Okay.
Okay.
So,
what
so
further
this
investigations? Yeah.
All right. So my investigations, I would like to send the blood investigation. First is complete full blood count with differentials count, looking at the total white, whether there's evidence of leukocytosis or leukopenia, looking at hemoglobin, whether we are dealing with anemia and chronic illness, or since this patient also on antiplatelet, whether the patient had, and another differentials is the GI malignancy, whether we are dealing with occult bleeding, and also throughout in elderly patient, nutritional deficiency. And looking at the platelet count, whether we are dealing with severe sepsis with thrombocytopenia, inflammatory markers, CRP, initials to guide, because we're going to start the first line antibiotics and to monitor the response, ESR to exclude whether this patient had tuberculosis, renal profile, looking at any evidence of septic AKI, and the baseline creatinine itself, because this patient had long-standing diabetes. I would like to know whether she had CKD. And another things, I would like to calculate the creatinine clearance prior starting initiation of antibiotics and any electrolyte imbalances this patient had in sepsis now. Liver function test, looking at the hypoalbuminemia and chronic disease or any transaminitis, whether there's a deep-seated abscess in the liver, or screening itself for the MAFLD in underlying long-standing diabetes mellitus type 2. Other than that, I would like to acquire coagulation profile, looking at the coagulopathy in a severe sepsis itself. VBG, because the DXT was very high, 16, I would like to exclude whether there is a concurrent DKA and send the serum ketone. Also send the serum osmolarity, whether this patient in HHS or DKA of the lab. Other than that, I would like to send urine FME, looking specifically into nitrates and leukocyte, whether there's a genitourinary involvement in a prolonged fever, whether we are dealing with abscess in genitourinary. Send the urine CNS to look at the culture, and send the blood culture itself to know what is the organism involved here. And baseline chest X-ray, my interest area looking at the upper lobe cavitating lesion or upper lobe mass, whether there's pleural effusions of empyema, dealing with fever of unknown origin. And ECG itself in sepsis, it could be arrhythmia. We are dealing with arrhythmia or any ischemic changes type 2 MI in severe sepsis. And also, if this patient we are dealing with malignancy, I would like to see whether there's evidence of pulmonary embolism by looking at tachycardia, RBBB, or S1 Q3T3.
Okay. Yes, he also had bowel symptoms initially. Any thing else that you would like to send?
I would like to send for the stool workup because this patient had antibiotic exposure, ruling out C. diff to send the CD toxin. And stool culture itself to look whether we are dealing with bacterial infective diarrhea in nature, and stool ova and cyst were manifestations. So that's for the stool workup itself, Prof. At this point.
Okay.
Okay. So this patient was initially impression of the pneumonia, differential with PTB or malignancy and according to antibiotic DKA. So Dr. Shairah have requested for this biochemical and radiological investigation. So the next we have the biochemical investigation of this patient. Dr. Shairah, will do any comments about the investigation? I can provide the baseline RP is normal and the stool investigation is all normal actually.
All right, thank you, Dr. Chong. So from this blood investigation, we can see from the pool blood count, there is a hypochromic microcytic anemia with reactive thrombocytosis. Most likely this patient have IDA. And the total white count is 9.3, is within normal range, I think, because of the partially treated antibiotic exposure, and predominant is neutrophils. For the renal profile, there is evidence of AKI here, urea is 23 with creatinine 152, with electrolyte imbalance, hyponatremia 130 and hypokalemia 6.0. Otherwise, calcium is within normal range. Magnesium is slightly hypomagnesemia with the normal phosphate level. For the liver function test part, this patient having hypoalbuminemia in chronic disease, or I'm not sure whether this patient had target organ damage in the diabetic, that this patient have microhypoalbuminuria in early stage of CKD. AST LT within normal range, and inflammatory marker CRP was raised. So this patient is having infection, bacterial infection, or we are dealing with abscess. Otherwise, urine FME ketones was negative, ruling out the DKA, protein only 1+. And this patient not in having metabolic or lactate acidosis in kind of this sepsis. And so far, sputum AB ×3 was negative, but at this point, still cannot rule out the smear negative PTB that we need the gene expert.
Good. So next we go on to the chest X-ray. We have the comment about the X-ray.
Right. So I can see from this chest X-ray, there is a bypass scar here noted. However, there is no upper lobe mass or cavitating lesions or any pleural effusions to suggest empyema or patient having pleural effusions. Otherwise, there is no reticular nodular shadowing or prominent airspace opacity over the lung field. The cardiac is there is no cardiomegaly. It's a quite normal X-ray, the Chong.
Okay. Sure. The next one, there's a ECG that you've requested.
So from the ECG, I can see it's a sinus rhythm. There is no evidence of a cardiac arrhythmia or no acute ischemic changes. It's only isolated inversion of a lead 3 and the V1. There is no RBBB or S1Q3T3, Dr. Chong.
Okay. So based on your initial impression and the investigation that I requested, what is your impression at the moment and what's the plan of management for the patient?
All right, so at this point, I will treat as partially treated pneumonia. And I will start the antibiotics, IV rosapine for this patient. Put her on drip as she's uncoated, borderline hypotension, giving resuscitation initially, and maintain with drip maintenance as this patient also have AKI. Close monitor IO charting and urine output and renal profile. Put patient on a Nesaprom, keep oxygenation more than 95%. I plan to start vessel bolus. At this point, we maintain the XT 10 to 12, start the PRN atropine first for her.
PRN atropine, I think the dextro sticks.
16.
16, yeah. We will start vessel bolus insulin for this patient, Prof. Sorry, she's not in DKA or she has no need to start the fixed scale insulin. With close monitoring the XTQID, I would like also to evaluate the echo in patient, since this patient is IHD post bypass, to look at EF also, and also any evidence of infective endocarditis. If she doesn't respond to my first line antibiotics, I will investigate further for the ultrasound abdomen to look at any deep-seated abscess on CT thorax, thorax, abdomen, and pelvis. Look at any deep-seated abscess in the organ or in the spine. Yeah.
Okay, so before we go to the other radiological investigations, so you mentioned just now she has anemia, and also you noted that she has hyperkalemia. So anything else that should be done for the patient?
All right, for the anemia, I will send the anemic workup, send the full blood picture, and it will send the TSAT and ferritin, look at whether this patient had the IDA, and together, since this patient is elderly, 67, we should send the nutritional workup as well, B12 folate. That's for the anemia part of. And then
she has hyperkalemia.
Okay, for the hyperkalemia part, I'm worried whether if you are dealing with malignancy. Okay, I will give lytic cocktail first, but if risk of suspicion we are dealing with malignancy, I would like to send also the uric acid, but other features doesn't fulfill tumor lysis syndrome. So I will give lytic cocktail stat and monitor the potassium closely, whether it's improved by hydration or by another lytic cocktail.
Okay, so you mentioned about tumor lysis syndrome. So what does it consist of?
Okay, so based on the Bishop criteria, is a combination of we look at the uric acid, calcium, phosphate, and also potassium, Prof. So it will be hypocalcemia, hyperkalemia, hyperphosphatinemia, and high uric acid in the tumor lysis syndrome.
Okay, so does it fulfill?
For this patient, it doesn't fulfill actually. But we don't have the uric acid. Looking at the calcium is within normal range, and phosphate is not really high.
Okay. So any other results that you would like to ask Dr. Chong? Okay, so this patient having fever. Okay, so you mentioned about pyrexia of unknown origin, kan? Okay, so any culture results that you would like to know?
Yes, Prof. So, initial investigation, I request to send a blood culture and urine CNS. So at this point, if we have the, I would like to know the culture so far, whether is any growth from the blood culture or urine culture, or any vegetation on the echo. Or if we have done CT EAP, I would like to know whether any deep-seated abscess in this patient.
Dr. Chong?
Okay, good. So we proceed further. So as what Dr. Shairah have mentioned, this patient, given hydration, the kidney AKI have resolved after admission, and the blood culture came back as a non-typhoid phenomenon, isolated, was sensitive to augmentin and amoxicillin. So the impression involved, they will change to non-typhoidal salmonella bacteremia. As we can see, the CRP was high at 20.8, PCT is borderline at 0.2, ASI is high at 88, TSAT is low, showing there's anemia with 5.63, LDH suddenly raised at 460, total culture negative, and initial virus screening was negative. So as planned by Dr. Shairah, was initially amputated with abriosulfine and changed to ampicillin based on the culture report. So the FPP of this patient, part is a post-translational film, but there's no features of hemolysis. And the white cell and the platelet changes slightly due to the reactive. You can see the amount of neutrophil myelocytes, and there's thrombocytosis. So this patient has been treated in the ward with antibiotic. From the initial admission, you can see the CRP about 20. She did initially responded to the antibiotic as the fever has subsided, but after about 1 week, although the CRP and the PCT is coming down in trend, the temperature started to rise again with the field temperature spike. So what is the next step of management? I think Dr. Shairah did mention about the echo and all that. And the procedure we have done, which is normal, during the for TB is negative, the viral and bacterial panel RP33 is negative as well. Echo has no vegetation, repeated blood culture has no growth. So
maybe Dr. Chong, you can explain a bit why, what is a gene expert? I mean, what does it imply? And also the RP33.
the gene expert mainly is because to detect the bronch, then the lavage, and then to screen for the pulmonary tuberculosis, especially whether it's a PTB, a smear-negative PTB, and RP33, there's a concept of panel about 33 pathogens, including of viral and bacterial. So we've shown that this patient basically actually have ruled out any lung infections on board. So the next step, I think Dr. Shairah has mentioned, well, Dr. Shairah, what's your next step you want to do for the radiological investigation? Either by ultrasound or CT scan, right?
Yes, it's CT-TAP or ultrasound abdomen to look at any deep-seated abscess or abscess.
Okay, so this patient, we have done the CT scan for her, and now we have to invite Dr. Emilia, the consultant radiologist from the radio department, to show us the CT findings of this patient. Thank you.
Okay, Assalamualaikum and very good morning to everyone. Thank you to the organizing committee, Prof. Rafeah, for inviting me today. So I'll jump straight to the imaging findings for this patient. So this patient had a CT multiphase that was done on the 31st of May, early this year. So this was the first imaging modality that was performed for the patient. So why is multiphase? So basically multiphase is basically more than a single phase. Usually in CT scan, what we do is in a venous phase, but in multiphase CT is 2 phase up to 5 phases, depending on the patient's indication. So at this point of time, CTA was requested as one of the differential was to look for, at the time of the request, it was to look for mycotic aneurysm and occult infection and malignancy. So we perform a CT 4-phase. Okay, so 4-phase means there is a plain CT where you don't give contrast at the beginning of the scan, and then you have the arterial phase where you can see there is maximum contrast opacification within the abdominal aorta. And then venous phase is when the contrast has gone into the venous system. And in delayed phase, we will wait for about 5 minutes, sometimes up to 15 minutes, to see the, to characterize the delayed enhancement or delayed washout of the lesion or whatever particular lesion that we are interested in. So that's why we proceeded with a CTA scan for this patient. So from this CT scan, what you can generally see is that within the liver, in this multi-phase CT, which is best seen actually on the venous phase, there are lesions over the liver, which if you scrutinize further, these lesions is actually iso to hypodense on the rest of the phases. Okay. Again, this is another example. Okay, how this lesion looks like in these phases. So this, let's concentrate on just the venous phase of this CT scan. So this is the venous phase. So Shairah, do you want to comment on the venous phase of this patient?
Okay, so from here I can see is it's multiple, irregular is hypodense lesions scattered all over the liver loops.
Okay.
Yeah.
Okay.
It's
All right.
very incised.
All right. Okay, so what we see here, as mentioned earlier, these lesions are basically hypodense. So we do not see any arterial enhancement in this lesion during the arterial phase. We do not see any progressive washout of this lesion. What we see is that multiple, like Shairah said, multiple irregular, it's varying in sizes, scattered in both the liver loops, in the left side of the liver, as well as the right side of the liver. So the right and left liver loop. Multiple, okay, and then, okay, as shown in the arrow, yeah? Okay, so you can also see in this axial scan, there are more sub-centimeter left para-aortic lymph nodes, okay? And for the bone window, we typically change the bone window CT to look for any suspicious bone lesion. So at first glance, there is nothing much peculiar about the CT scan of the bone. But what you can, when we scrutinize further, what we see is that there are subtle sclerosis of the thoracolumbar spine. But it is not lytic, there was no extra-osseous soft tissue component that we typically see in a metastatic bone lesion. Okay. So let's recap. So there are multiple hypodense liver lesions scattered in both liver lobes. They are non-arterially enhancing. There are multiple few sub-centimeter left para-aortic lymph nodes and only mild sclerosis of the vertebral bodies. Okay, so at this point of time, we go by the clinical presentation of the patient. So radiologically, given the history of bacteremia and pyrexia of unknown origin, so multiple liver abscesses was one of the top differential diagnosis for this patient. So these lesions are hypodense, and the degree of hypodensities actually differ. So it could be like liquefied or non-liquefied abscesses. And then another differential, the second differential that should be think of is metastatic liver lesions, but we don't see any primary tumor in the CT scan. To suggest it's a metastatic liver lesion. And the third would be a multicentric HCC. Unfortunately, there is no evidence of liver cirrhosis because if patient had liver cirrhosis, we will expect the liver outline to be a little bit more nodular, which patient did not have. And this lesion has no typical findings of HCC, which is arterial enhancement and progressive washout. So there was no findings to suggest a multicentric HCC. So the first two was the differential diagnosis after the first CT scan. Okay.
Thank you, Dr. Emilia. So I think one of the differential diagnosis just now was tuberculosis. What is usually the findings that you would get from the CT, of the vertebra?
Vertebra. Okay, for tuberculosis, basically tuberculosis can cause spondylodiscitis. Okay, so it affects the end plates of the vertebral body. So there will be the disruption of the end plates before it affects the disc. and it will have collection of phlegmon at the paravertebral with subligamentous collection, which we do not see in this patient. So it just, for the vertebral body, it was just a subtle sclerosis. There was no evidence of destruction. There's no evidence of a soft tissue or collection to suggest either a pyogenic or tuberculous spondylodiscitis at the moment of CT.
Okay, and for the first differential diagnosis, so the hypodense lesion could represent liquefied or non-liquefied abscesses. Is there other radiological modality that can help to differentiate this?
Yes, definitely. Ultrasound abdomen, ultrasound hepatobiliary system would be very good for us to see the consistency of these liver abscesses. Because if it's liquefied, it will be more cystic on ultrasound. But if it's non-liquefied, then it will be in between solid and cystic, the content of the liver abscesses.
Okay, thank you, Dr. Emilia. Okay, Dr. Chong? You are muted.
Okay, thank you, Dr. Emilia. Let me share back my screen. So, Dr. Shairah, after the CT scan as presented by Dr. Emilia just now, do you agree that we treat the liver abscess now and then we reassess with ultrasound subsequently?
Sorry, yes, Dr. Chong. At this point, I will treat as a liver abscess.
So
Yeah.
let's proceed. So after the CT imaging was done, as we can see there's a liver abscesses with intra-abdominal lymphadenopathy due to disease disseminations. We have revised our impression to non-trophitis salmonella bacteremia with liver abscesses. So at this moment, you can see that the CRP and the P-stability actually is fluctuating, and the further investigation has come back that has shown that the atypical screening was negative, melanosis was negative, fungal culture was negative. Our initial plan was to continue antibiotic for at least 4 to 6 weeks and ultrasound reassessment in the wait time to see the improvement after the antibiotics.
Dr. Chong, is there any attempt to aspirate the?
Yeah, Prof, I will mention in the next slide. Yeah.
Okay, sure.
Okay. So initially we haven't done an attempt before that, but after 2 weeks of antibiotic, we did a reassessment with the ultrasound. So this ultrasound has shown there's a multiple ill-defined, partially liquefied hyperacute liver collection. As described in the CT scan, we have shown no significant interval changes. And as you can see, the temperature of the patient in the ward, there's still fingering up and down on and off fever. So we did attempted to try the ultrasound drainage of the liver abscess to remove the source. However, there's still non-liquefied segmental liver collection and only able to aspirate about 2 cc of thick blood, only able to send for the pus culture and not enough to send for the TB culture and all that. So as a recap, for this patient, you can see she admitted at almost end of the May with these symptoms, culture low salmonella species treated with antibiotic, and after the 1 week antibiotic, we know that CT-TFP has shown there's multiple liver abscesses. Reassessment after the antibiotic about 2 weeks, they show no significant changes. Attempted for this liver abscess drainage, but it's not really successful. Only thick blood aspirated. Suggest to wait further another 1 week for the reassessment with ultrasound. So at this moment, we have reassessed with the ultrasound after about 1 month of duration in the ward. So this ultrasound has shown there's an unchanged multiple liver lesions, and there's actually few ill-defined hypercoagulation now in the spleen. At the one from the spleen has spread to the spleen and may represent the splenic microabscesses in the correct clinical settings. So, and for the blood parameters, parameters, you can see that PCT actually is not raised. CRP is hanging from 20 to 13. Culture, apart from the first admission, the rest of the culture is negative. The bronchoscopy, when done, as mentioned earlier, is normal. TB workup, the mental, everything is normal. Echocardiogram have no vegetation. CTP screening was negative. Atypical screening negative, but the ultrasound had persistent liver abscesses with a new splenic lesion at this moment. And the drainage only shows the thick blood, culture no growth. And antibiotic total duration almost about 1 month with the rosofin about 10 days, ampicillin 7 days, and even Tazol 7 days. So Dr. Shairah, at this moment, what are your other differential diagnoses and what will you do in the next step of management for this patient in view of persistent temperature, low inflammatory markers and all that?
So for this patient, since she is not responding to already 1 month given antibiotic, there's a new abscess in the spleen, despite liver. So at this point, the top diagnosis will be malignancy. I will get the IR team basically to get a biopsy for us here from these lesions to look at what type of malignancy we are dealing with.
What type of malignancy do you suspect in this patient?
Based on the
Based on the-
history of findings and also clinical findings and the radiological investigation results that were presented just now. Okay, so you mentioned about malignancy. So what malignancy is broad, as you know. Okay, so what type of malignancy are you thinking of?
At this point, the top list in my differentials could be we are dealing with hematological malignancy, where in someone in elderly, it could be a lymphoma, Prof. But the type of lymphoma, we're not sure. We should wait for the biopsy part.
Any other malignancy that you can think of? She's a lady. Okay, there's liver lesions. Okay, there's also some possible lesion in the bone. Dr. Shairah? A non-hematological malignancy?
It could be metastatic disease, Prof.
From? Where's the possible primary? Okay, so don't forget breast cancer. Okay, she's a lady, kan?
67.
Yeah, okay, so with liver lesions and also the bone lesions, but of course it's not typical lah, the bone lesions. Okay, so usually for breast cancer, what would be the typical, the typical bony lesion if there is metastasis to the bone? Is it lytic or sclerotic?
Yes. I think it's sclerotic, Prof. I am not really sure.
Dr. Emilia?
Sorry, for breast cancer, is it? Bone mets. Usually you can have both lytic sclerotic mets for breast cancer.
Yeah.
It's not just sclerotic.
Okay, thank you.
Okay.
Dr. Chong can...
Yeah, sure, we proceed. So for this patient, and finally we proceeded with the liver biopsy, and we have to invite Prof. Dr. Wong to review the answer for us about this patient diagnosis. Thank you.
Thank you, Dr. Chong. Let me share my screen. First of all, I would like to thank the organizing committee, Prof. Rafeah, for the kind invitation. So I will talk to you, present to you the microscopic examination findings of the liver biopsy. Right? Okay. So what we receive is 2 strips of liver tissue measuring about 2 centimeters in diameter, in largest dimension. So we will, what we see is, there's extensive areas of necrosis with the relatively bluish area, which comprises of sheets of tumor cells. So the tumor cells, neoplastic cells, relatively medium-sized, small to medium-sized, where they are relatively discohesive. So there is no specific pattern like glandular formation or like squamous differentiation you can see here. So at higher magnification, more of the same, that we can see the relatively discohesive malignant, neoplastic cells, where they display round to oval with slightly irregular nuclear outline borders. They exhibit hyperchromatic nuclei, and there's has no nucleolus as seen here, and they have very scanty cytoplasm with mixed stem looks blue under low magnification. At this point, you can at this magnification, we can see one mitosis. Actually, there's a few mitoses seen elsewhere. So this is an area that we show extensive areas of necrosis that's seen. However, in the included strip, we don't see any liver tissue, and there's no neutrophilic aggregates to suggest that it's abscesses. So when we are dealing with small round blue cell, it's not relatively small, but this is our when you're dealing with a small round blue cell tumor, there's some differential diagnoses we will want to entertain. The first in the list, of course, is lymphoma. When the tumor cells are relatively discohesive, they're round with very scanty cytoplasm. Of course, in the phase when we're dealing with multiple liver lesion, as in this case, we will entertain metastatic neuroendocrine carcinoma, including small cell CA from the lung. And very rare down in my list, there is primary neuroendocrine carcinoma of the liver, but it's rather unlikely in this case, looking at this multiple lesion with, usually the primary usually will be more solitary. All of that, they look the same, almost the same microscopically under microscope. So there is some immunohistochemistry panel that is actually very helpful for the distinction. That's why from the initial H&E, we will proceed with a panel of immunohistochemistry. So since a lymphoma is high in my list, so I will, of course, I will do some initial lymphoma panel. We'll do CD20. CD20 is a pan-B marker. So if it is a B-cell lymphoma, it'll be positive. Another useful lymphoma B panel that you can use is CD79 alpha. And CD3 is a T-cell marker. And if it's a T-cell lymphoma, it'll be diffusely positive. In this case, the tumor cells is actually negative, and they will just stain the reactive T cells, which is together with the tumor cells. And this is this is a CKAE1, AE3, which is a pan-epithelial markers. So if it is metastatic carcinoma, it will be diffusely positive. And the K67 is, so it is negative in this case, so carcinoma is actually excluded. K67 is a proliferative marker that we used, and in this case, it is highly proliferative. It's about 80%. So from this point of time, this is our first panel. From here, we have narrowed down our differential diagnosis. This is a high-grade B-cell lymphoma that we are actually dealing with. So in our differential, of course, DLBCL, diffuse large B-cell lymphoma, is one of the high in the list. We will want to exclude Burkitt's lymphoma, a follicular lymphoma, a grade 3B type, and a mantle cell lymphoma, a blastoid variant. So these are the differential diagnoses of a high-grade B-cell lymphoma. Another panel of immunohistochemistry we will do to further narrow down our differential diagnosis. CD10 and BCL2 is the germinal center markers that is if it is like a follicular lymphoma, which the B cells actually rising from the follicles, they'll be positive for the germinal centers. So in this case, CD10 is negative, BCL6 is positive given nuclear staining, and BCL2 is a very good marker if we were dealing with we are actually concerning whether this is neoplastic follicles or versus reactive hyperplasia. So in this case, BCL2 is positive, and it is also very useful when we're dealing with a DLBCL. And if it is positive, it shows as a double expressor. And MUM1 is post-germinal center markers. And if it's in a DLBCL, we want to subtype it, and we will do a MUM1, and it's positive in this case. So, okay, so here from the immunohistochemistry panel, we know that this is diffuse large B-cell lymphoma, with excluded follicular lymphoma being CD10 is negative, blastoid variant of mantle cell lymphoma, being that this is the BCL6 is positive, CD10 is not the germinal cell marker, and the Burkitt's is negative, is excluded, being the CD10 is negative. So yeah, this is Hans' algorithm that we use to further subclassify DLBCL to germinal center type and non-germinal center type. In this case, we have CD10 negative, BCL6 positive, MOM1 positive, so we're dealing with a non-GCP type DLBCL. So this is our final diagnosis, diffuse large B-cell lymphoma of the liver, germinal center B-cell type. With that, I thank you very much.
Thank you, Prof, to review the answer. So, Dr. Shairah, let me share back my screen. You have the answer of the diffuse large B-cell lymphoma now. So, how will you proceed for the next step?
All right, so for this patient, I will do a pre-chemo workup for this patient.
Sure.
Because of the subjective
Yeah, sure. For the family counseling, and then you do a staging, especially final diagnosis with the PET scan. So, any comment about the PET scan, Dr. Shairah?
So this is a widespread disease involving supra and infradiaphragmatic and multiple organs. So it's already stage 4. Yeah, it's not good. And IPI score is roughly about 4 to 5.
Sure, we will mention about it later. So we're going to invite Dr. Emilia again to share with us the PET findings. Thank you.
Okay. Okay. Subsequently, about more than a month later, PET-CT was performed for this patient. So you can see there is high metabolic uptake scattered at the liver, correspond to the liver lesions that we saw. And there were also uptake in the nodes, subcentimeter nodes that we saw, and in the bone as well. So you can see that the mild sclerosis that we saw on the CT earlier on actually shows uptake in the PET-CT. So as mentioned by Shairah, it involves the cervical nodes, the bones. It's most likely stage 4, right? Nodal and extranodal progression of these lesions. All right. So multiple hypermetabolic uptakes involving the liver, nodes, and bone raises a suspicion of a metastatic disease. All right. So just touch a little bit about the imaging conundrum of hepatic lymphoma. So basically, hepatic lymphoma is an uncommon diagnosis. Okay, it can be primary or secondary, and in primary is usually solitary up to 60%, but it can be multiple as well. And in secondary, most of the time there will be multifocal lesions. And as you can see that the enhancement pattern for this lesion is both heterogeneous. All right, so it's actually quite difficult to determine whether it's a primary or a secondary hepatic lymphoma because some of the features overlap. Okay, and if you come across a multifocal hepatic lymphoma, multifocal liver lesions, okay, these are the differential diagnoses, and you can see that the top 4 is actually associated with infection, although it's quite uncommon to get a tuberculosis or sarcoidosis liver pathology. Okay, and the last one of the differential is metastasis, as we've already mentioned earlier on. So these are some of the images that a hepatic lymphoma can actually look like, whether it's secondary or a primary. So in this image, in the secondary hepatic lymphoma, is more rounded, well-defined, homogeneous, hypoenhancing hepatic lesions. And in this primary hepatic lymphoma, they are also multifocal with one dominant mass. Okay, it's hypoenhancing enhancing lesion. Okay, other features that a hepatic lymphoma can have from these articles that I got is it can have a target-like pattern. They can have multiple hypoattenuating lesions, and some will have miliary pattern. So when these findings may be confusing with abscesses, micro abscesses, especially if the features appear this way in these splenic or liver lesions, because micro abscesses will look similar as well. And the last one is a patient with a large matted node with infiltration into the liver, very ill-defined, you can't make out the margin. So these are the imaging findings for hepatic lymphoma. It's not very typical, it is variable, making the diagnosis quite challenging for radiologists. Okay. I think that's all from my slides.
Okay, thank you, Dr. Emilia. Okay, Dr. Chong, would you like to conclude?
Yes. Thank you, Dr. Emilia, for the radiological differential. So let me proceed with my slide. So for this patient now, we can see that disease is like a DLBCL stage 4, IPI risk about 4, and CNS IPI 5. Why is the scoring is important that I will mention later. So think about DLBCL. We have a brief content for this summary. So DLBCL, large B-cell lymphoma, actually there are 70 entities under the large B-cell lymphoma, which DLBCL not otherwise specified is defined as a large cell morphology, mature B-cell phenotype, lack of criteria defining other specific large BCL as noted over here, the ALK positive, CNS lymphoma and all that. So according to the Malaysian National Cancer Registry report in 2012 and 2016, lymphoma actually is the 4th more common cancer in Malaysia, which is recorded about 5.1% in total, just behind the breast, GI, and the lung cancer. A similar study was done, carried on the private center as well during that period, has shown that out of this BNHL, DLBCL actually the most encountered with 30 to 50%. And the incidence peak increases at the year of 70s. And you can see above 50 years old, they become more and more common in this kind of patient. So the pathology have, as Paul mentioned before, there's effectiveness of normal architecture but medium to large lymphoid cells, then express of CDB cell marker like CD19, 2079A, and then we have this classified based on the cell origin into a germinal B cell center or activated B cell with the selected markers we use is CT test, BCL6, and MAN1. So the workup, if any differential suspected of the DLBCL to confirm the diagnosis, actually is best to get the excision or the true core biopsy of the lymph nodes, the extranodal mass, or there's bone marrow, even if you suspect the marrow infiltration. The fine needle aspiration is usually not recommended because of the limited cells that are available. And then we do the assessment of the patient general condition, like we do the routine blood, FBC, the renal profile, LFT, the LDH, the viral screening, and the with the echocardiogram as well. After we assess the patient condition, we did a staging. Once analysis is confirmed, we do the PET or the CT if the PET not available. And marrow sometimes is not necessary if the PET CT has shown there's a high uptake in the marrow or the skeletal uptake. So for the staging wise, we use the staging. We divided the stage 1 to stage 4, which is stage 1 just involve a single nodes or the adjacent nodes. Stage 2 involve the 2 or more groups at the same side of the diaphragm. I can use the diaphragm as a separator. Stage 3 wise, there's a disease involve the upper and both the lower diaphragms. And the stage 4 is a widespread disease as we see in our patient, involve the organ involved like the lungs, the liver, or the marrow. So prognosis wise with the DLBCL, we use the IPI or revised IPI criteria, and the factor involved like the age, performance status, LDH, erythrocyte, and stage. So if you can see our patient, the age is 67 years old, performance status is still okay, about 1, LDH is raised, erythrocyte is more than 2, with the liver, marrow, skeletal involvement, adrenal, and the stage 4. So we put her under the revised IPI score, a bit of poor risk prognosis with the overall 4-year overall survival about 55%. So apart from that, we also have the CNS IPI because as we know, the high-grade lymphoma, they have a CNS involvement. So it's similar as an IPI, but we just added on the kidney or adrenal gland involvement. So our patient will be the high risk in view of the age, the LDH, stage of disease, erythrocyte, and the adrenal gland involvement. Treatment-wise, the chemoimmunotherapy is still the mainstay with the R-CHOP21. 21 means about 3 weeks of the duration of each cycles. It consists of rituximab, cyclophosphamide, doxorubicin, vincristine, or prednisolone. Radiotherapy alone is ineffective unless it's the localized disease with bulky disease might show a good outcome. And also the maintenance rituximab may show no benefits after completed 6 cycles of R-CHOP, thus it's not recommended. So how about CNS prophylaxis as we mentioned earlier? So with those patients with DLBCL treated with R-CHOP or other chemo regimes without CNS improvement at the baseline, we calculate the risk score, calculate the risk IPI score, low risk, intermediate risk, and high risk. If those with low risk with some organ, especially like testes or the breast, we still need to give some CNS prophylaxis. Those intermediate risk with the high risk cytogenetic and the high risk patient, we will consider give CNS prophylaxis. The CNS prophylaxis can be given like an intrathecal therapy about 4 to 8 doses, or there's IV MTX or at least 2 to 4 courses. And those patients with low risk IPI score less than 4 without any site involvement, or there is no high risk cytogenetic, there's no CNS prophylaxis required. So how about the role of consolidative high-dose therapy or transplant, autologous transplant in this group of patients? So that is remain controversial. A lot of studies have shown that there's no overall benefits different in overall survival in this patient undergoing the transplant, but with causing a higher rate of toxicity. Meta-analysis also published evidence also revealed that it's a heterogeneous result with no overall survival benefit. Thus, consolidative autologous transplant or high-dose therapy in CR1 patient is not routinely recommended. So how about our topic today with hepatic lymphoma? It can be divided into primary or secondary involvement as mentioned by Dr. Emilia earlier. Primary hepatic lymphoma actually is very rare, actually considered about less than 1% of all the cases of lymphoma or axonal lymphoma. The risk factor of developing the hepatic lymphoma like HIV, immunocompromised, Hep C. Imaging modalities is helpful defining the hepatic lesion, but we still need a clinical suspicion of the lesion at the time of staging is a bit difficult. So biopsy is the lesion is the next step in the diagnostic chain. Is clinical suspicions arise because help to avoid the confusion between is it a metastatic malignancy or is it abscess or is it a cancer. So chemotherapy remains the mainstay of the treatment. With complete remission can achieve more than 80% of the patients. So last but not least, the summary and the learning points. So when we encounter the liver lesions, always have a differential in mind like infection, tuberculosis, metastasis, ACC, or lymphoma. And DLBCL remain the most common BNHL encountered. Hepatic lymphoma is very rare actually and difficult to discriminate from a liver abscess. So imaging alone is insufficient to conclude the diagnosis. And the biopsy, so remember biopsy is recommended for the definitive diagnosis. R-CHOP remains the center of care for the first-line therapy. And although complete remission rate can be more than 80% of the patient, there are some still population of the patient who have refractory or relapsed disease with a poor outcome, especially when the late diagnosis. With that, I end my slide today. Thank you.
Okay, thank you, Dr. Chong, for the outline of what lymphoma is and commonly diffuse large B-cell lymphoma. And for this patient, there is liver involvement. A bit difficult to say whether this is primary or secondary hepatic lymphoma. So I would also like to congratulate Dr. Shairah for going through the case with us. Thank you to Associate Prof. Dr. Wong and also Dr. Emilia for your valuable input. Okay, I think we go through the quizzes after this. Okay, so I think before we go through the quizzes, so again, I would like to thank everyone as usual. Okay, so thank you for your contribution in this CPC. Hopefully everyone has gained some information and knowledge on what lymphoma is, and they may present they can have an atypical presentation, okay, so not just with lymphadenopathies. All right, okay, so thank you everyone, have a nice day.
So much.
Thank you, Prof, and everyone.
Thank you, Prof, and everyone.
Thank you.
Cik Buhari, the quizzes ada?
Bentar.
Okay. Is there any prize for that?
Dah lama dah kita maklumkan, tak apa saya maklumkan sekali lagi.
Okay.
Hadiahnya semasa anugerah sanjungan kencana nanti.
Okay.
Pemenang terbaik. Satu saja. Terima kasih.
Alright.